So good morning everybody. Welcome to the world of cells and flare. So this is a Uvea free paper session, and before starting our session we will request Professor Jyotirmay Vishwas sir for his keynote address.
Good morning to all. The title of my keynote address is Histopathology, Immunohistochemistry and Molecular Biology in Eviscerated and Enucleated Specimen of End-Stage Ocular Inflammatory Disease. No conflict of interest. I will be describing the histopathology, immunohistochemistry and molecular biology correlation in various end-stage ocular inflammatory pathologies. Many eyes of that end-stage ocular inflammatory pathologies are enucleated or eviscerated. These eyes are discarded. But if we look carefully, we can have valuable information from these priceless specimens. This is a retrospective chart analysis of 18 eviscerated or enucleated globes secondary to intractable ocular inflammation due to multiple etiology over a period of 10 years conducted in a tertiary eye care center in South India. Histopathology, immunohistochemistry and molecular biology study was carried out from the paraffin section from the eviscerated or enucleated specimen with various stains. We discuss each case. VKH and sympathetic ophthalmia. If you look at that one, VKH will get the non-granulomatous inflammation, CD3 as well as the CD20 positivity was seen in the VKH specimen. Sympathetic ophthalmia showed granulomatous inflammation with predominant CD3 positivity. And here is the picture. The pointer is not coming. The pointer, the light is not coming. Excuse me. The slide. If you look at that VK specimen, and you can see that there is a CD20 B cell marker positivity in that slide. In case of sympathetic ophthalmia, you see the numerous inflammatory foci that stained positive with a T cell marker, and there is a CD3, there is a T cell positivity is seen here. In tubercular panuveitis, in 3 cases of tubercular panuveitis, the mycobacterium tuberculosis genome was detected by nested and real-time polymerase chain reaction in 3 cases. But acid-fast bacilli was seen within the retinal pigment epithelium cell only in 1 case of TB panuveitis. This is a 25-year-old male who had a dimness of vision of right eye 6 months, month 2 HSCD chest was positive, monthly chest was positive. HSCD chest was normal. The eye was painful and blind with the retinal detachment. The intractable painful blind eye, this was removed. And histopathology, if we see, there is a caseation necrosis which is seen in the arrow. Caseation necrosis is seen in the arrow. Lymphocytic infiltration throughout the retinal layers and the uveal tissues. PCR from the paraffin block showed MTB genome, both the nested and both nested PCR, MPB64 and I6110. In 2 eyes of each disease showed chronic non-granulomatous inflammation around the blood vessels of the retina. Immunohistochemistry showed CD8 positive T cells. There is a T suppressor cells. PCR showed Mycobacterium tuberculosis DNA from the paraffin section. And here you can see the MPB DNA in that both the MPB 64 was positive. IS6110 was negative. There is inflammatory cell infiltration in the retinal layers. In the case of East disease patients, in the other eye which was showing features suggestive of East disease, the eye which is painful and blind was removed, and you can see the histopathologically multiple vascular channels surrounded by lymphocytes. These lymphocytes were CD3 positive, that is T cells, and these T cells was particularly T suppressor cells. In the case of pars planitis, we could find out the acellular tissue with chronic granulomatous inflammation in the RPE and HPE histopathologic section. And immunohistochemistry showed both CD68, CD3 and CD8 marker positive, CD20 was negative. In acute retinal necrosis, showed chronic non-granulomatous inflammation in the retina and occluded retinal blood vessels and herpes virus inclusion bodies. Nested PCR was positive for varicose-zoster virus. And here you can see that inflammation in the peripheral retina, occluded blood vessels, and the CD3 positive T cells and viral inclusion bodies and herpes virus zoster DNA in nested PCR as well as the real-time PCR. In the case of tuberculous scleritis, the eye which was treated with the systemic steroid immunosuppressive agents could not be salvaged, and the eye became painful and blind. The eyeball was removed. This enucleated globe on histopathology showed chronic granulomatous inflammation with giant cell reaction, and PCR of the paraffin section showed Mycobacterium tuberculosis DNA. And this is the case of tuberculous sclerosis which was removed as a tumor, and on the histopathology you can see that on gross examination there is a mass lesion in the choroid and which mass lesion in the sclera, and these scleral lesions were showing chronic granulomatous inflammation, and there is a RP within the RP cells, acid phos bacilli was seen, and agarojol electrophotogram showed positive MPB DNA for AS6110 and MPB64. In conclusion, knowledge regarding various ocular inflammatory disorders is still evolving, and histopathology, immunohistochemistry and molecular biologic study of the enucleated globes and eviscerated specimen in end-stage inflammatory disease can give valuable information and provide insight into the etiopathogenesis of such several uveitis, retinal vasculitis and sclerouveitis, which in turn can develop various efficient therapies in future. Thank you very much.
Thank you so much, sir, for your valuable inputs and the importance of histochemistry, particularly the immunohistochemistry. Thank you so much, sir.
Thank you.
So I have one question for you, if I can please ask.
Please.
Yeah, so like you presented this case of tuberculous sclerouveitis, which you had enucleated. So in that specimen, usually do you recommend going for FNAC in such cases prior to proceeding with
No, actually, the FNAC would not be really the sclerouveitis case. The patient was a painful and blind eye already, and FNAC would not have really valuable. And if you see in early stages, if there is a mass lesion were there, good ultrasound and final aspiration biopsy or choroidal biopsy can be of beneficial in such cases.
I see. Thank you, sir.
So we are going to start that Uvea free paper session, and the first speaker is Dr. Sanyukta Kadam. Our paper is on pattern of pediatric uveitis in the patients of Northeast India. Dr. Sanyukta Kadam. She is not here, she is absent. Okay. The next speaker is Dr. Shivangi Kapoor, and she is presenting on the pattern and profile of pediatric uveitis in a tertiary eye care hospital in post-COVID era. She is present.
Good morning everyone. Today I am presenting my paper on pattern and profile of pediatric uveitis in a tertiary eye care hospital in post-COVID era. There are no financial interest. As we know, pediatric uveitis accounts for 2.2 to 21.65% of patients in various uveitic clinics worldwide. It is a very special and challenging group of patients with regard to the diagnosis and management of uveitis. These are the various landmark studies done to study the pattern and profile of pediatric uveitis. It includes Bishwas et al. Study done in India, Martin et al. Study done in Australia, Hamadi et al. Study done in Saudi Arabia, Peroli et al. In Italy, and Smith et al. in USA. So again, the purpose is to describe the pattern and profile of pediatric uveitis in a tertiary eye care hospital. For this purpose, 114 eyes and 99 patients were included in our study. 16 years or younger in age. Study period was January 2021 to December 2022. Complete ophthalmic evaluation of these patients were done. Uveitic classification according to Sun classification on anatomical basis was done. Tailored laboratory investigation was done to know the etiology. Among the 852 uveitic cases, 99 pediatric uveitis cases were included. Age range was 11 months to 15 years. Unilateral cases 84 cases and bilateral 15 cases. Male to female ratio was not significant. Anatomical classification, according to it, 2/3 of the patient, that is 66.7% of patients were of anterior uveitis, intermediate uveitis was 15.2%, posterior was 12.1%, and pan-uveitis cases were 6.1%. These are the various etiologies. Among them, idiopathic was the most common. 36 cases were idiopathic, and pars planitis, 12 cases were there, so it is also included in the idiopathic. Non-infectious, again, idiopathic was most common, followed by JIA, 12 cases, traumatic, 9 cases, and among the infectious etiology, we got tuberculosis, 10 cases, toxoplasmosis, 6 cases, toxocara, and viral uveitis, 3 cases each. 70 patients were responded well to corticosteroid only, 13 patients immunosuppressive were used, cataract surgery was needed in 9 patients, and glaucoma surgery in 3 patients. These are the various complications noted in our study. Cataract was present in 19 patients, cystoid macular edema 13 patients, 8 patients had glaucoma, band-shaped keratopathy in 5 patients, 2 patients had optic atrophy, retinal detachment was present in 1 patient. There were no complications noted in 51 cases. So, as we compare our study with the various landmark studies, anterior uveitis is the most common type. In our study, 66.7% cases out of anterior uveitis. Idiopathic remained the most common etiology of the pediatric uveitis cases, 48.5% cases. Among the infectious etiology, in the various studies we can see worldwide, toxoplasma is most common. But in our study we can see tuberculosis is 10.1% and toxoplasmosis is 6.1%. So to conclude, pediatric uveitis accounts for 11.61% of cases of uveitis. Anterior uveitis is the most common type. Idiopathic etiology is still the most common type of uveitis among the various etiologies. Toxoplasma is the most common cause of infectious uveitis among children worldwide. However, in our study, tuberculosis, that is 10.1%, was the most common etiology. Conclusion, pediatric uveitis is a very special and challenging subset of disease with regard to diagnosis and management. Early diagnosis and timely intervention of appropriate treatment is the key to preserve and maintain the vision for long term. These are my references. Thank you.
So a very nice study, Dr. Shivangi, but I would like to ask you a few questions. Why you have decided to do this profiling of this pediatric uveitic patients?
there was a surge of uveitis cases in our OPD. So we tried to study the trend if it is following in the pediatric age group also, because as we know uveitis is an immune related process. So we are trying to, as the children are having a stronger immunity and immune reaction, we were trying to see the trend in the pediatric age group.
Okay. And there are so many studies like Paroli et al. Or even by J.B. sir also. The toxoplasma is found to be the most common etiological agent,
Yes,
but in
sir.
no study
Yes,
what
sir.
I noticed that it is TB actually which is having around 10 patients or 11 patients you were
So 10
showing there
patients.
that they were having tuberculosis. So I think this is beyond the normal set trend or the normal set etiology. So what is your take on this? Why this?
So this we found different in our study because there were 10 cases of tuberculosis and 6 cases of toxo. In other studies, we saw that most common cause of pediatric uveitis infectious cause was toxoplasmosis, but in our study, it was tuberculosis. So there was a hypothesis that it can be post-COVID, there can be decrease in immunity, there can be reactivation, and post-COVID there is some parenchymal infiltration also, so there can be reactivation and there can be a steroid use history also. So we documented the cases, but there was a poor follow of the patient, so we didn't tabulated that data.
And you have done this study in the post-COVID era, so how many patients you will be thinking that these things are occurring because of that COVID?
So we took the history. There were 16% patients who had a positive history of COVID that was documented, and with rapid antigen test or RT-PCR was done. But in most of the patients, large number of patients, there was a recall bias. There was fever history or something, but there was no documentation of the treatment or the any lab investigation, so we didn't tabulated that data and added in the table.
Okay. Thank you so much.
Yeah, all your cases were definitive cases of tuberculosis or they were presumed cases? How did you...
No, sir. We did Montoux test was done, and initially we ordered only Montoux test and chest X-ray POV. If the Montoux test was negative or some chest X-ray finding, we were indefinitely ordered quantiferon also. So all the patients were recorded, the tuberculosis, and we referred to the physician also.
So they were diagnosis were based on quantiferon gold test, you're saying?
Few cases, not quantiferon gold test, on chest X-ray and Montoux test only, and the presentation.
Okay, thank you.
No, that is not allowed. No. You can discuss it off the podium. So the next presenter is Dr. Mahel Sarthak, and he is presenting a case of bacteroidinitis with panuveitis in a young male. Dr. Mahel Sarthak, please. Since
your presentation will not be included in competition.
your presentation is not considered as a...
Because only ratified members up to the membership number 27309 were eligible for award. However, every member can present, but the presentation will not be considered for the award. Yes. Next presenter is Anisha Vijayan. Is she present?
Anisha Vijayan.
No, let us know. Manogya Jain. Manogya Jain. Are you present? No. Aparna Maredi, Dr. Aparna Maredi. Yeah. Please be ready with your presentation here. We should not waste much time. Dr. Aparna, you please ready with in the other podium with your presentation. We don't want to waste much time here. You will be the next presenter. Dr. Meghna Dikshit. See most of
Neha Sudhakar. Okay. Dr. Namrata Shri.
Yes.
Dr. Sukanya Padhi. Dr. Veena Devswani.
Last. Yeah, that.
So, a patient with a 15-year-old male presented with a painful swelling in both the upper limbs and redness in both except one week. There was no history of any such previous episodes, no systemic complaints, no any systemic illnesses, no history of trauma, fever, joint pain or cough, and no significant family history. His best-rated visual acuity in the right eye was 6'9" and the left eye was 6'9". There was temporal swelling and temporal congestion present in both the eyes, and all other findings were normal. The picture here showing bilateral swelling in both the upper eyelids. I have a picture here showing everted upper eyelid with the swelling. On examining on day 5, the patient's visual acuity in the right eye was 36. There was circumcortical congestion, haze, erratic precipitates, 3 plus cells and a 1 millimeter hypopion. There was also pigment on the anterior lens capsule and mid-ritis. In the left eye, there was a vision of 636. Temporal swelling, circumcortical congestion was present with 1 plus cells. Rest all findings were within normal limits. I have a slit lamp picture here showing the hypopion, which is about measuring 1 millimeter, and congestion. He also had lesions on the web of his finger, for which he was sent for dermatology consultation. Patient was found to have scabies, for which the treatment of permethrin and ivermectin was started. Rheumatology consultation was done to rule out any systemic immunological illnesses or any connective tissue disorder. A blood profile showed raised CRP and ESRP. There was no abnormality on chest X-ray, both AP and PA view. The liver function test and creatinine were within normal limits. Blood test for serum H, RA factor, ANA, thyroid autoantibodies, ANTA, anti-SSA, SSB antibody, and virus-associated immunoglobulins were all within normal limits or negative. The imaging showed a hyperintense lesion in the superior part of the orbit. The patient was diagnosed as a case of bilateral darkness and pan-uveitis and was started on topical steroids, oral antibiotics, topical cyclobatics, and oral anti-inflammatory. After administering the treatment, he was examined again on day 15. Now his vision in the right eye was 6'9", the swelling had reduced, the congestion had reduced, there was fewer erratic precipitates, the cells were 2+, the pupil was pharmacologically dilated and broken synechiae was seen. The lens, there was pigments on the anterior lens capsule seen. The left eye, the vision was 6 parts, swelling had reduced, the congestion had reduced, and there were no more cells present. The pupil was pharmacologically dilated and all other parameters were within normal limits. So darkness usually causes local symptoms such as swelling of the lacrimal gland and the upper eyelid and temporal conjunctival injection. Pan-uveitis is an extremely rare complication of darkness. The most common cause of acute darkness is usually infectious, more commonly viral followed by bacterial, and are typically unilateral and seen in children. Pan-uveitis causes are exogenous or endogenous infection, injury, or an autoimmune disease. This is an extremely rare entity, and only one sample of this case with simultaneous anterior uveitis and dactylitis has been reported so far. The most common complications arise from misdiagnosis or delayed diagnosis. So our case had a presenting history of diagnosed scabies, and all other possible causes of acute dactylitis and pan-uveitis were ruled out with comprehensive laboratory and radiological investigations, which narrowed us to a probable cause of being infectious and probably spread from the skin. What is unique in our case? It was a young individual. He did not have any systemic illness. He was immunocompetent, no connective tissue disorder, no infective etiology, and all immunological parameters were within normal limits. So a bilateral presentation of dactylitis and pan-uveitis is an extremely rare condition, and in this case, despite all our parameters being normal and the patient not having any systemic illness, still we develop bilateral ocular inflammation. So we need to be active in our treatment in prompt in our diagnosis to prevent any further complications. These were my references. Thank you.
Thank you so much,
Sarthak, what investigations have you done in this case? So interesting case, very interesting case. Bilateral acroadenitis presenting with pan-uveitis. Yeah. So what were actually you thinking in your mind that what it can be? Have you done that serum AC and serum lysozyme titers? So whether these serum AC titers were done before starting steroids or after starting steroids? Before starting steroids. And Mantu? Mantu? And HRCT chest? So you have ruled out sarcoid and other things. Okay, thank you so much. Any other question?
Thank you.
So our next speaker is Dr. Aparna Maridi, and she is presenting on serpiginous choroiditis, the enigma.
Thank you. Why didn't you think of starting anti-tubercular treatment, one? And second, why did not you consider Ozurdex as a treatment? Because he was a young patient. That's okay, but still it doesn't answer my question. Why not oral anti-cox treatment, anti-tubercular treatment? Why not? And what about Ozurdex? So the cost was the factor. Thank you.
Dr. Aparna, you have done so many investigations. I was wondered that why that C-Anka, P-Anka was done in this case. And when you are suspecting it's a case of tuberculosis origin, even MAN2 positive or quantiferon negative or MAN2 negative doesn't rule out TB. Your patient was worsened initially and then you hike up the dose. Second thing, that when this type of presentation is there, you should rule out syphilis. Nowadays, syphilis is on rise. We are seeing so many patients of syphilitic uveitis, and syphilis is a great, great mimicker. It can present like ARN, it can present like sarcoidosis, it can present like anything. So that thing was, and whenever you are suspecting it's an infectious etiology, please don't give any depot injection or intravitreal injection, because if you are going for even PST, that is really going to cause havoc. Thank you.
So we call the next presenter. It is Dr. Neha Sudhakar Pereka. She is going to talk about her presentation on to identify the prognostic factors in Rod-Koyanagi-Harada disease.
Yeah, Dr. Namrata Sri, please be ready with your presentation. Yeah, they should be ready with the presentation. Namrata Sri, Dr. Namrata Sri. Is she present? Yeah, please come forward and you can forward the backward there. Yeah, Dr. Sukanya Pari.
Dr. Sukanya.
Yeah, please come forward. If your presentation is ready, we will start with it. Let us not waste time in between. Let the next speaker's presentation be ready.
Next two speakers, please keep your presentations loaded because we are short of time.
No, it is not here. Yeah, now we can start.
Dr. Sukanya, your time is up. Please conclude. Thank you so much. So our next speaker is Dr. Neha Sudhakar, and she is discussing to identify the prognostic factors in walk coronary heart disease. Dr. Neha. Dr. Namrata is there in the hall. Huh? The presentation is uploaded. Huh? Okay. And Dr. Veena, madam, your presentation is uploaded. Huh? Okay, thank you so much. please summarize yours.
Thank you, Dr. Neha. Did you find any of the conclusions which are not something unusual that is already reported, something different you found in your study? So even that is a predictor, like the fluoride is a predictor of a disease which is... Okay.
Okay. So our next speaker is Dr. Veena. She is presenting on herpetic hypertensive uveitis after cataract surgery, mimicking as low-grade endophthalmitis. Dr. Neha, your presentation is uploaded now. Oh, sorry, Namrata, your presentation is uploaded now. Okay, so next. Madam, please summarize your study. Summarize your study. Your time is up. Conclude.
No.
Thank you.
Okay, thank you so much, madam.
Okay, so we request the next presenter, Dr. Namrata Shri. She is going to present clinical and etiological pattern of anterior uveitis in southern Assam, a hospital-based study.
By that time, Dr. Sanyukta Kadam, please upload your presentation and get ready. Yeah. Whether Dr. Anisha Vijayan and Manogya Jain, so no more. Meghna Dikshit, no, she is not there. Thank you so much. Our next and last speaker of this session is Dr. Sanyukta Kadam, and she is presenting on the pattern of pediatric uveitis in the patient of Northeast. Thank you so much. So the Uvea free paper session is over. Thank you all the audience and the participants who have given their valuable time and presented their study. Thank you so much.
We'll proceed with the next session.